Hi, I'm Arturo Molina, Chief Medical Officer at Protagonist Therapeutics. Today, I'll be talking a little bit about polycythemia vera, which is a myeloid malignancy characterized by excessive proliferation of red blood cells. As a result of overproduction of red blood cells, patients are at risk of complications such as thrombosis and heart attacks. Also, patients can develop symptoms of fatigue, problems with concentration, severe itching, and other constitutional symptoms. The goal of treatment in polycythemia vera is to keep the hematocrit levels or the red blood cell levels below 45%. Some of the currently available medications succeed in doing this, but for many patients, despite standard of care treatments, which include phlebotomies, hydroxyurea, interferon, and ruxolitinib, some patients still require frequent phlebotomies because of the inability to control the hematocrit. Rusfertide is a mimetic of hepcidin. Hepcidin is the master regulator of iron in the body, and in patients with polycythemia vera, there's an association of reduced hepcidin. What we have found with rusfertide is that it very effectively and selectively decreases the excess red blood cell production that can be observed in polycythemia vera. And the data we are presenting at ASH is the final analysis of a randomized phase 2 study that we have presented in the past and we published in the New England Journal of Medicine earlier this year. At this ASH meeting, we will present the final results from the phase 2 REVIVE study investigating the hepcidin-mimetic rusfertide in patients with polycythemia vera. The phase 2 REVIVE study design consists of 3 parts. Part 1 is the dose finding, where the dose is titrated to achieve hematocrit control in the patients with polycythemia vera. Part 2 was a blinded withdrawal, where patients were randomly assigned to continue treatment with rusfertide or go on an active placebo, a blinded placebo. And then part 3 is the open label extension where all patients continue on rusfertide. And the response was defined as meeting phlebotomy eligibility, in other words, not having the hematocrit control. So patients whose hematocrit went above 45% and was 3% higher than the time of study entry, or patients who achieved a hematocrit of 48% or increase of 5% compared to their pre-randomization value. Basically, REVIVE met the primary efficacy endpoint in the pre-specified analysis. The response rate in patients randomized to rusfertide was 69% compared to about 15% in the patients who were in the placebo arm. The focus of the presentation at this ASH is to show the durability of response. What we demonstrate is that now some patients have been on treatment for 3 years or longer, and the slide that I'm showing shows that hematocrit remains controlled or under 45 during the duration of time on treatment. The other unique finding from this study is demonstrated in this slide, which shows that rusfertide increased the mean corpuscular volume, the MCV of the red blood cells, throughout the study. And so patients, paradoxically, in polycythemia vera, suffer from severe iron deficiency, in part because the uncontrolled red blood cell production, the erythrocytosis, depletes iron stores, and then patients lose iron when they get frequent phlebotomies. So it's like a vicious cycle where patients have very high hemoglobins and hematocrits, they get phlebotomies that depletes their iron, And in all this time, the iron's also being depleted because of this uncontrolled red blood cell production. And one of the manifestations of iron deficiency is that the MCV is diminished. And so these cells that have a lower MCV are not as healthy as the red cells, which have a normal MCV. So we believe that part of the mechanism of action, in addition to controlling hematocrit, is potentially making the red blood cells a little healthier. In this slide, we show the phlebotomy requirements in patients at the time of or right before study entry. So there's two figures, the one of patients who have been treated with phlebotomy only on the left, and on the right, the figure shows the phlebotomy rates for patients who are treated with phlebotomy and cytoreductive therapy. And what you see is that before coming on study, patients, every red triangle that you see represents a phlebotomy. Then during the green part is part one of the study where there's the dose optimization. And there you see that there's marked diminution in the number of phlebotomies that are required. And then in part two, where half the patients are randomized to placebo, the patients in placebo now require phlebotomies. And then in part three, you see that for the most part, with long-term follow-up, most of the patients remain free from requiring phlebotomies, or their phlebotomy requirement is substantially diminished. In this slide, we show that rusfertide improved several symptoms assessed using the MPN-SAF throughout the duration of the study. When we first published the results in the New England Journal earlier this year, we reported improvement compared to baseline of several important symptoms that affect patients. These symptoms include fatigue, the itching, abdominal discomfort, and problems with concentration. And what's very gratifying to see is that this improvement in patient-reported outcomes is also observed during the long-term follow-up of the study, so that the patients who had moderate or severe symptoms prior to coming on study entry, you see that a variety of the symptoms remain improved while the patients are on treatment. And we believe that this results in an improvement in the quality of life for patients with polycythemia vera. Regarding safety, the majority of treatment-emergent adverse events are grade 1 and 2. There have been no grade 4 or 5 treatment-emergent adverse events. 18 patients experienced SAEs. The most common treatment-emergent adverse event is injection site reaction, which is seen in many patients, the majority of patients, but most of the time there's no treatment required for the ISRs, and these are transient and do not prevent the patient from continuing on treatment. Patients do experience fatigue, and that is part of the symptom of polycythemia vera. And the other symptoms that patients experience are the itching, which again are characteristic of polycythemia vera. Patients with polycythemia vera have an increased risk of malignancy, particularly non-melanoma skin cancer. In this study, we have been following patients and they get periodic dermatologic exams. 9 patients developed skin malignancies, which were treated with curative intent. And by doing routine dermatologic exams, we detect these lesions early and they're readily amenable to treatment with curative intent. 7 thrombotic events have occurred while on treatment in 6 patients. This is, again, one of the complications that arise in polycythemia vera. All the patients who developed the thrombotic events were patients with high-risk polycythemia vera. We have not observed thromboembolic events in low-risk patients in this study. So in conclusion, rusfertide added to therapeutic phlebotomy with or without cytoreductive therapy controlled erythrocytosis, provided long-term durable control of hematocrit, and decreased the need for therapeutic phlebotomy in patients with polycythemia vera. Because the majority of patients participating in the study have requested to continue on treatment, even though the REVIVE study has now been completed, earlier this year we initiated another study, the THRIVE study, open label extension, where approximately 50 of the patients in this study have been rolled over to continue open label treatment for 2 additional years. Finally, the ongoing randomized phase 3 Verify study is evaluating rusfertide plus therapeutic phlebotomy with or without cytoreductive therapy versus placebo plus therapeutic phlebotomy with or without cytoreductive therapy in patients with polycythemia vera. The trial finished enrollment earlier this year, and we are waiting the unblinded results of the study, which we anticipate in the first quarter of 2025.